Fibromyalgia is a complex and uncertain condition that affects millions of people around the world and can affect a variety of people that you will see regardless of whatever speciality you are in, which can make these conversations quite difficult. But today, on this episode of Clinical Communication, I'm joined by Derek Griffin, who is a specialist musculoskeletal physiotherapist and, like me, has a particular interest in fibromyalgia and chronic widespread pain. On this episode, we're discussing what we can say when someone wants to know more about their fibromyalgia and their situation, and some of the pitfalls or challenges that can come with that. We're discussing specific terms that may have been useful in the past but aren't as useful anymore, and how to manage expectations and have realistic optimism. I've put the social media links for both Derek and I in the description to this episode. If you want to send me an email, you can send it into clinicalcommunication@outlook.com. And there is still time to join the Pain Practice OS course with Dr. Mark Cardula, where I'm also involved. That'll be starting soon. I'll put the link in the description as well. If you've enjoyed this conversation, please do go share it with others. Please do subscribe. Thank you for listening or watching, as always, and I'll speak to you soon. There's still a lot of, I feel like it's less than it used to be, but there still feels like there's a lot of, I'd say misunderstanding or, you said stigma, not knowing. I tell people all the time that when someone with fibromyalgia or a similar condition will sit down in front of me, I'll say, apart from hopefully people in our service or other people with this condition, most people will sit in that chair that you're sat in and will tell us that the rest of society, and their family, and anyone else in their life doesn't understand because they don't have a crutch or a cast or a big sign that gives it away. We could go into town right now. We could look across a bunch of people in an audience. We couldn't say who's got fibromyalgia, who doesn't. You could same thing for other long-term conditions, couldn't you? Um, I think that I found lands quite well because they feel that you've got it a bit. They've been misunderstood for a while. It really obviously depends on their journey. Some, again, from experience and from seeing them now, some are telling stories where they've had very supportive, whether it's GPs or other people they've seen who have been on board straight away. They may have had other family members who have it or know of someone, and it's easier to relate to. But it's also not unheard of now still that I'm the first person they speak to who they feel that, after 10, 20 appointments, who actually has a vague idea of what's going on and what they're dealing with. How are you finding it over in Ireland, the patients' experiences of their with fibro before they come to you?
Yeah, so it obviously varies. So it's quite common, I'm sure, as it is in the UK, for people to see multiple practitioners even at the same time. There's many different beliefs among the general public
Mm.
on what fibromyalgia is or isn't. And it's I suppose it is quite rare that somebody would come to me where they already have an up-to-date evidence-based idea of what fibromyalgia is. The most important thing is that when you give them the opportunity to tell their story, listen to them with intent, and through reflective questioning, show that you have listened to them. They, as you alluded to earlier, they're often quite surprised that you get it and that they don't have to um, try to explain themselves as to why they're not doing a lot of exercise or why they're not sleeping. They almost feel guilty at
Mm.
times
Mm.
and they feel that they have to justify that situation to you. So when you just give them permission you know, to tell their story and reassure them that you understand why they're doing what they're doing and how this is impacting on many aspects of their life. I think that sets the foundation for then looking at what we might do about it. Yeah. So it is still quite common that regardless of what they understand about the condition, that just for it to be accepted
Mm.
and for them to feel that it's not their fault, I think is a key consideration for clinicians.
I had that conversation today, actually. Someone, interestingly, they'd been diagnosed 25 years ago, right? And this is obviously years ago when at that point it was this diagnosis of exclusion. They go through the mill, they have all that, and then they get labeled. And at the time, obviously, support and awareness of it was not as what it is now. And hadn't really had much input. And I'm seeing them, a quarter of a decade later, century, sorry, later. And we're having the conversation. Actually, this is the first time she said someone had talked to her about it. It's like, how have you gone this long? But it does happen, doesn't it? People, if they're, and often with these people that are the doers, they're coping, right? They're just plugging on through. They may go years without actually wanting to or needing to go back to healthcare until there's a crash. And then something happens and it just pushes them over the edge again.
And I think that leads from the whole uncertainty around persistent pain in general.
Yeah,
It's much easier to talk about an ankle sprain than it
yeah,
is fibromyalgia. Not that ankle sprains can't be terribly complex,
yeah,
but at a fundamental level,
yeah,
they're explained by the anatomy and
yeah,
and the mechanics of the ankle. So I think clinicians are much more happy to talk about ligaments and tendon and the response to load and progressive loading because it does follow principles. There
yeah,
is the mechanotherapy stuff, the how a muscle responds to load, how a tendon responds to load. There is a strong science that underpins that, but
yeah,
but pain fundamentally is so complex and influenced by so many factors across the lifespan that I think sometimes clinicians are as fearful as the patient themselves, and
yeah,
sometimes it's not dismissed in a kind of in a way to dismiss the patient. It's just clinicians aren't maybe confident in how do we bring up the topic of fibromyalgia? How do we explain it? Where do we go with it?
Well, let's go with it. So, obviously, you and I used to having the conversations all day with people. We've had it 10,000 times, but there'll be plenty of people watching or listening who it's new to. So, if we go the classic example of someone in their 40s, 50s, and let's say they've had the diagnosis given, the scenario I guess I see the most of is they've been to rheumatologist. Rheumatologist said nothing inflammatory. They get the diagnosis, maybe a handout. And then they say, oh, there's a lovely physiotherapist and refer you to them, or occupational therapist, or psychologist, or whoever. And they sit down and they say, I've been given this diagnosis, but I don't know what it means. And let's say for this situation, they want to know more. Where do you start?
So I suppose you always start with the listening bit.
Of course.
You
Yeah. Yeah.
know, I cannot explain to somebody what fibromyalgia is if I don't listen to their story because
Yeah.
their story and their current understanding should and will shape my conversation
Mm,
around what it is or isn't.
yeah.
I suppose fundamentally fibromyalgia is a symptom-based disorder.
Yeah.
We get a little bit bogged down too early about what is the pathophysiology, like what are the mechanisms underpinning it. But the diagnosis is entirely based on symptoms.
Mm,
We
yeah.
don't have a biomarker, we don't have a specific test. It's a
Yeah.
it's a symptom-based disorder primarily characterized by generalized widespread pain, in addition to other symptoms, including things like fatigue, unrefreshing sleep, waking up unrefreshed,
Yeah.
um, psychological comorbidities around anxiety and depression, cognitive dysfunction, memory issues. And there was a framework developed in 2016 by the American College of Rheumatology, where there are clear diagnostic criteria,
Yeah.
which kind of summarize the score based on the number of pain sites and all of these other symptoms.
Yeah.
And I suppose they classify people into do you have fibromyalgia or don't you? But we know that the symptoms exist on a continuum
Yeah.
from some, across. I'm not talking specifically fibromyalgia here, but I'm talking people with persistent pain will present on a continuum from a very localized pain problem to a
Mm,
widespread pain problem that has all of these other comorbidities around insomnia and cognitive dysfunction and fatigue, etc.
mm,
So rather than seeing it as a yes or no kind of diagnosis, I think it's important that we don't get too bogged down by the diagnostic category or the label per se,
yeah.
but recognizing that this is the end of a continuum. So we call it fibromyalgia when the extent of pain is widespread enough and they have these other symptoms to such an extent that it's impacting on their quality of life.
Mm.
And that's the diagnostic box of fibromyalgia.
Yeah. Yeah.
So I think it's important to have that conversation with the patient that we diagnose this based on your symptoms,
Mm.
and we have emerging scientific evidence around why what might underpin these symptoms, but more importantly, we believe you that it
Yeah.
is not uncommon for these symptoms to cluster together.
Mm.
And just reassure them that all of these, particularly the vaguer symptoms like the sensitivity to things like cold,
Yeah.
or the IBS type symptoms.
Mm.
And often when you ask so the patient may not often volunteer these symptoms. When you ask them, do you have any sensitivities to lights or sounds or smells, they're almost surprised that you ask them the question,
Yeah.
because they haven't been asked that before. They
Mm.
haven't felt the need to say it because they might not link it to their primary symptom, which might be pain or fatigue. So
Mm.
through our questioning, we can actually show them that we're interested,
Yeah.
and that these symptoms they're not in their head. They're not actually that unusual. Fibromyalgia is relatively common across the population. Widespread pain is common across the population.
Mm.
So, that I suppose that's the first part of the diagnosis, and understanding the diagnosis, that, it's symptom based, and we see these all the time. It's
Yeah.
not unusual, and we believe you. You
Yeah.
know, then that sets me up nicely into looking at, okay, where do we go with this in terms of what might underpin those symptoms? Now,
Mm.
this is complex because
Yeah.
you know, you and I are physiotherapists. We're not immunologists. We're not
No.
physiologists. So, I can give them an overall summary of, the broad concepts around what we think might be going on. But I'm reluctant to, get caught up in the detail being too sciencey,
So.
or it being very brain centric or
Mm.
nervous system centric. We need to keep our explanations very patient centric.
Yeah.
So, that I suppose that brings me to, what scientifically do we understand around the symptoms of fibromyalgia now? We know that there's involvement of both the peripheral and the central nervous system.
Yeah.
So, is it a condition of central sensitization? No. Is central sensitization present? Yes, but
Yeah.
that doesn't mean that we can, fibromyalgia is not synonymous with central sensitization. We see changes in the peripheral nervous system, in the central
Mm.
nervous system, in the brain. It's a person problem.
Yeah.
So I rarely go down that route of, central versus peripheral sensitization. I will usually try to come up with some kind of an analogy.
Yeah.
And I suppose fundamentally, fibromyalgia is not a diagnosis of exclusion.
Mm.
And that's very clear in the 2016 diagnostic criteria. So it doesn't mean that people with fibromyalgia don't have some issues in the tissues that are worth exploring, or,
Yeah.
or, or worth treating.
Mm.
I routinely see people that meet the criteria for fibromyalgia, but will also have knee osteoarthritis,
Yeah. Yeah.
or they may have a very stubborn gluteal tendinopathy.
Mm.
And I don't think it has to be one or the other. There is a role for understanding that entire picture,
Yeah.
because if we are true to looking at the drivers of fibromyalgia, some of those drivers may be in the peripheral tissues. And
Absolutely.
over time, that develops into a more widespread pain condition. So there is a role for that. So I would never discount the tissues. I might very well talk to them about how, of course, depending on the situation, if somebody has a very clear, problem with knee osteoarthritis that's limiting their function, and that has
Mm.
come out in their history. They're telling me that their walking is limited by knee pain. They have knee stiffness in the morning. They have, trouble bending their knee. It's clearly an issue.
Yeah.
Then a part of my reasoning may look at how ongoing inflammation in the periphery, like with knee osteoarthritis, may over time lead to more changes throughout the nervous system that make other parts of your body hurt. And there may be role of actually looking at and addressing
Yeah.
that knee pain as part of a much bigger picture. But we clearly know that in terms of the pathophysiology, there's an upregulation of inflammatory mediators.
Mm,
There's an emerging evidence around the role of neuroinflammation, which is basically an
mm,
inflammatory response of the central nervous system. Um, there's this fascinating body research coming out at the moment around the role of autoimmunity.
yeah, yeah.
And I know we explored that, that very, I suppose, difficult to answer question: is there an autoimmune component to this? And the emerging evidence would suggest that at least in a subgroup of people, that there definitely seems to be a role of
Mm,
the immune system. That people with fibromyalgia have the presence of autoantibodies that are in some way winding up
yeah.
the nervous system. They're winding up that nociceptive system. And I suppose this is an important point of our conversation, Ben, where I think we need to make sure that when we're talking about the immune role, or sorry, the autoantibody role or the autoimmunity role in fibromyalgia, it appears that it's not your classic inflammatory
Yeah.
stuff. So it's not to be confused with things like rheumatoid arthritis or
Mm,
psoriatic arthritis or these very classic inflammatory disorders. So characteristically, fibromyalgia will lack the signs and symptoms
mm.
of
Yeah, yeah.
like synovitis, swollen joints, dactylitis. It won't have that pattern. So just because there's an autoimmune component does not mean that it's going to be treated with anti-inflammatories or biologic
Mm,
medications. So that's really
yeah.
important. And you know, I might use, again, going back to my analogy, I might, when I'm talking about, say, the nociceptive system to a patient and how the immune system can influence that both positively
Mm,
and negatively. I'm more and more reluctant to kind of get into the nitty-gritty of what a nociceptor is. I'll
same.
often use an
Yeah.
example of, someone previously having a wrist fracture or spraining their ankle.
Mm,
And,
yeah.
the body, that results in an inflammatory response, and that inflammatory response wakes up these nerve endings that supply the tissues of your wrist or your ankle, and they're basically this messenger system that tells the brain that something is going on in your ankle or your wrist.
Yeah.
And we now know from emerging evidence that it's not just injury that can wake up this system.
Mm,
So things like chronic poor sleep,
yeah.
things like chronic stress, it has the ability to change how this system works, even
Mm,
in the absence of a ongoing injury.
yeah.
So I'm always bringing it back to this event or events that they can relate to. So that you might have heard me talk about biologizing the psychosocial. And that's kind of what I mean, is that we need, the minute you start talking about, like, how things like stress and life stress events and all of this stuff can precipitate or be a risk factor for the development of widespread pain. The message sometimes is that, oh, it's all in your head.
Yeah, yeah,
Or
yeah.
actually it's having an effect, a profound effect on the physiology,
Mm,
just like an injury would. And
yeah.
I suppose the classic example that people can relate to is, the pain that comes with having the flu
Mm,
or, COVID, in recent times.
yeah,
That's not an injury, but that's an immune mediated increase in the function of the nervous system, the nociceptive system. So, the pathophysiology is extremely complicated,
yes, yeah.
and within a group of people with fibromyalgia,
Mm,
we don't know that the underlying mechanism is the same across all those individuals.
yeah.
For some, there may be a stronger autoimmune component. For others, it may be driven by things like, we know that low-grade inflammation, systemic low-grade inflammation, as opposed to the classic high-grade inflammation that we see in something like rheumatoid, immune dysfunction, and upregulation of inflammatory cytokines, all of these things that in themselves are then shaped by our lifestyle, our physical activity, our
Mm,
stress, our life events. It's really complex. So our journey to pain starts from when we're born, and it's shaped across the lifespan. from previous life events, early life
Yeah.
events, particularly important,
Yeah.
right up to when we develop symptoms. So, I think it's much too complex to say to the patient, this is definitively what's causing or not causing your pain.
Yeah. Yeah.
We can have a very open conversation with them
Yeah.
once we've listened to them and kind of have a feel of where their current understanding is, and then take them on the journey through rehabilitation. It doesn't all have to be done on the first session. And
Yeah.
that's something when I'm doing any teaching that I reiterate to students. The old model of physiotherapy of you have your assessment and then your treatment doesn't sit well with me.
Mm, yeah.
That assessment is ongoing all the time, and that conversation that you're having with the patient is ongoing over the course of their rehab journey. It's never a one session scenario.
No, I completely agree because they will change. Their life will change. I think of tons of people. Well, if you think of COVID as an example, 2019, who were managing their widespread pain, and then obviously everything happens, life changes, and then how well they're feeling changes. And that's not just, that's across all the biopsychosocial factors that's addressing. That's not just, because of stress or because of um, they can't get out as much. It's all those different factors. And I've done about you. You were saying about the immune and the inflammatory stuff. I've been finding myself say when it comes to people asking what's going on and they want to know more, I find myself saying nervous system less these days, and just saying body more. I realize that's slightly into the bio and the psych, but considering we know that, as you were saying, that there's so many different systems are involved. It's not just your nervous system sensitive, right? And even just central. And even if nervous system, what do people think of? Brain, number one. And again, it gets that message. Um, I just find myself saying it less and less these days, and it's quite. I don't think it's changed uh, outcomes for better or worse drastically. Yeah, it's too early to say. Um, but I think you're spot on with if you come and they say, why have I got this? Yeah, no, that trauma you had when you were, that's immediately, even though you're not saying it, there's that classic phrase of they won't remember, what you said or what you did, but how you made them feel. Well, how you're making them feel it's all in your head. Even if you're not saying it or if you don't mean it, it's giving the impression and they'll take that.
Absolutely, I totally agree. And that's where I think analogies are really useful.
Mm, yeah.
Things like, as I said, the pain that comes with the flu. Like
Mm,
people are happy to believe that, the flu is this real thing. It's a virus and it can change your physiology. And as part of the symptoms that you get, including things like fatigue, pain is going to be one of them.
mm,
I do not think we need to be talking about, peripheral and central nervous system and, the mind body. I totally agree with you. I think we've got lost in that whole space where, we're over explaining
yeah. Yeah.
rather
Yes.
than really looking for what does this patient need and want. They want to be listened to, they want to be believed, they want to be heard.
Yeah.
I'm not an immunologist.
No, no.
I'm not going to be able to explain to them in any, strong detail about the
Yeah.
precise immune changes that are happening. But
Mm,
but at a fundamental level, I might say to them, look, our immune system protects us and it protects
yeah.
us against injury.
Yeah.
And you get this big immune response when you sprain your ankle, but it also protects us against other traumas,
Yeah.
and life events and stressors that are ongoing. And, we get this huge barrage of inflammatory mediators and other immune responses. And as part of this, it changes our physiology to the point where we can be sore without being damaged.
Yeah. Yeah.
You know,
Absolutely.
if
Yeah.
take a classic example of DOMS, people go to the gym and they're sore the day after doing a lifting program. They don't ask for an explanation as to
No.
why they're sore
No.
because it's clear in their head that I lifted a weight, it did something to the muscle, and now I'm sore.
Yeah.
So it's the being believed bit.
Mm,
It's that kind of this isn't in my head bit that's more important than
yeah.
talking about the nervous system or
Yeah.
whatever else might be
Yeah.
going
I,
on.
I always tell people what do they want to know? Ultimately, they may not care. They may not want to know why or what's going inside them, how they may just want to know how to manage it and what to do moving
Absolutely.
forwards.
And just before we move on from that, Ben, I think it's very important sometimes for the clinician to say, I don't fully understand that either.
Yeah.
So because sometimes patients will have a symptom or a variation of symptoms or the behavior of their symptoms that just, that confuses me as much as the patient.
Yeah, yeah.
And I might say something to them, look, it's not uncommon that people talk to me about things like this or have these weird and wonderful symptoms. We don't fully
Mm,
understand them,
yeah,
but there more than likely is a very good reason as to why these symptoms. We just don't have all the answers yet.
yeah.
Pain is weird and wonderful at the same time, and I'm quite happy saying, I don't want to give you an answer to that because I'm kind of making it up. That
Mm.
it's okay to say, there's clearly a reason for it, but we don't fully understand that yet.
I'm interested. Do you say when much at all when it's secondary? So that if they've got the classic is inflammatory arthritis and then the secondary fibromyalgia after it, and I make an assumption, obviously never having either condition, that uh, an inflammatory arthritis is easier to get your head around because you have said scans and said findings and and fits and it seems more, again, this is an assumption on my end, legitimate because you've got findings with that compared to the fibro. I often find myself, that's there. The secondary fibros come, whether it's with or later, not hardly going into too much at all unless they really ask, because they're hopefully already bought into managing it through the inflammatory bit. And the fiber is just we can help it give us some extra inflation if needed, but it's kind of the add-on. And I've never found that delving into secondary fiber and the details of that when they've got a primary anything else seems to make much difference, in my opinion, from my experience anyway.
Yeah, that's interesting. I suppose firstly, it's very important for clinicians to understand, as you've just alluded to, that fibromyalgia can be secondary.
Yeah.
I know the terms have probably gone out of fashion, the whole idea of primary versus secondary fibromyalgia, and fibromyalgia is often classified under this newer concept of primary chronic pain.
Yeah, it's
Um,
true.
but it's very, very important to realize that, and I see this all the time, that people will present to me, and yes, they will meet the criteria for fibromyalgia. So again, it's not a disorder of exclusion, but
Mm,
it's important that they may actually have another condition that
yeah.
requires a different treatment approach, or at least a treatment approach in conjunction with other stuff that you might do. And in those scenarios, so where somebody comes in and they may have undiagnosed, it'll be like a spondyloarthritis, for
Mm,
example. It'll be less likely to be something like rheumatoid because rheumatoid sometimes is a bit more obvious. The
mm.
diagnostic delay in rheumatoid is 2 to 3 years, whereas for something like psoriatic arthritis, it can be up to 10 years
Oh, wow.
because of, rheumatoid will often present with the classic, synovitis, the swollen small joints and all of that. Sometimes the spondyloarthropathies can be a little bit less obvious. So they
Mm,
often go under the radar. So if someone comes in and I suspect they have an underlying inflammatory condition,
mm.
then before I kind of get into any nitty-gritty stuff around diagnostic labeling or what we might do
Yeah.
with it, I will refer into that multidisciplinary team, into rheumatology, and just clear that up because you might be familiar with a few years ago, Gary McFarlane's group in Aberdeen, I think.
Mm,
They looked at how the symptoms of fibromyalgia changed when the
mm,
patient started a biologic drug.
go on.
And it was quite impressive that a large percentage of people, their fibromyalgia symptoms improved concurrently when
Mm,
the underlying inflammatory driver was addressed,
mm.
you know.
Yeah, interesting.
And no, not everybody,
Mm,
but a substantial, so enough to think like this is really important. So it's really important that if you do suspect they have something like rheumatoid or psoriatic arthritis or a neuroendocrine disorder, whatever it might be,
yeah.
that you get them prompt referral and prompt treatment. But then you will have people where their their classic inflammatory symptoms are very much controlled with their biologic medication or whatever other treatments may be on, and yet they still have significant pain and fatigue. And, so that the fibromyalgia needs to be managed concurrently.
Yes.
And
Yeah.
I think we'd be naive to present to the patient that, that their inflammatory condition hasn't shaped their their fibromyalgia. Of
Mm.
course it has,
Yeah,
you
of
know, and
course, definitely.
there's obviously genetic variations as to why some people will respond really well and other people will continue to have these more widespread symptoms. Um, but I think w when you then again listen to these people, firstly, they'll have spent years and years often looking for a diagnosis. They'll have,
Mm.
even with the classic inflammatory signs.
Yeah.
And as part of that, they may have developed secondary anxiety or depression because they've had all of this pain, they've not been listened to. You know, they may have had to change their job or in some scenarios stop working. It has had huge effects on their social, family life, all
Mm.
of which we know in the long term sustain pain and feed into this neuroimmunology that shapes why somebody might have ongoing pain despite their inflammation being very well controlled. So again, I will shape my explanation around, well, look, you know, you've had this for so long,
Yeah.
you've developed all of these other things that have come secondary to your symptoms
Yeah.
and use, you know, get them to, I suppose, again, going back to them being heard, having the opportunity to talk about these other symptoms and reassuring them that, you know, all of these other factors, the, you know, the poor sleep now, the, you know, that you're not exercising as much as you once did, that
Mm.
you're not sure what to do, that you're fearful, all of this has led to things like deconditioning, et cetera, that has made, you know, do we say the system more sensitive, you know, but has made the
Yeah.
has contributed
Mm.
to the ongoing symptoms and pain. So we
Mm.
need to now look at, now that you have a diagnosis of psoriatic arthritis or whatever it might be,
Mm.
that's been managed with medication, but now we need to look at how do we address those other factors that have developed over the last number of years. So
Yeah.
whether that's a sleep intervention or whether that's looking at a graded exercise program
Yeah.
or whether they need cognitive behavioral therapy input, saying now that we combine to now address the big picture stuff.
Yeah. The sensitivity is really interesting because we were
Mhm.
speaking last week, and I often ask people about the hardest conversation. You said, well, actually, it's where the sensitivity and that conversation goes wrong, right? And often it can, it's a term that's been bandied around so long now, around it. And we were saying earlier about, nervous system is saying it less. It's more about there's various body parts. Um, what can I ask? What's gone wrong? You said there are these times where it's just not landed, or you said offended someone as well. Is that right?
Yeah, so I think ultimately we need to ask ourselves, what is sensitization? So sensitization is a biological construct.
Mm.
It's a change in the function of the sensory neuron. You know, so if you cut your finger and you rinse it under a hot tap or you press it, it hurts because there's a change in the sensitivity of the sensory neurons that innervate your finger.
Yeah.
Okay.
Yeah.
But when we talk about sensitivity in general and what the public understand by sensitivity, it could mean a variety of different things. So a sensitive person is seen as a, you know, as maybe someone that's a bit emotionally fragile,
Mm.
that's very
Yeah.
reactive to things. So suddenly you say to somebody, this isn't an injury, this is just you're a bit sensitive.
Yeah.
You know,
Mm.
so
Yeah.
now we're in trouble. You know,
Yeah.
so you're a bit sensitive. You know,
Yeah.
I get what the clinicians mean it means, but to the patient, that could easily
Yeah.
come across as they're just not trying hard enough, that they're not, you know, that they're not fighting this pain, that they're, you know, that they're sore because they're just a bit of a, they're being a bit dramatic. You
Yeah.
know,
You're
so
being sensitive. Yeah.
it's not a term that I tend to use a lot, or when I do use it, I'll try to use it in context. So I'll
Mm.
very much say to them, look, the sensitivity I'm talking about is not sensitivity and what we're used to hearing. It's like
Mm.
I might use the analogy of, you know, a cut to the finger, that it's an actual physiological process
Yeah.
that's happening. And now imagine that finger has healed, but yet those nerve endings are still misbehaving. That's sensitization.
Yeah. Yeah.
That's, it's nothing to do with your behavior or your psychology.
Yes.
So yeah, I think for such an obvious term, or a term that's in such common use, that I do wonder about how patients interpret
Mm.
that. So
I
we
said,
say to people, you know, like, going back to the conversations on manual therapy, it's
Yeah.
reducing sensitivity. We assume that the patient knows what that means.
Mm.
There's an assumption that sensitivity is a better way of talking about pain than injury,
Yeah.
that we're not changing the structure, we're not changing the injury, we're reducing sensitivity. And, I'd be under the impression that to somebody that doesn't know from a physiological perspective what sensitization is,
Yeah.
that they could misinterpret that in a number of different ways and
Absolutely.
leave thinking you've told them it's in your head, even though that's not what you think.
No. Yeah, if you're right to say you are sensitive can easily backfire. Uh, I don't know. I find sometimes you have to try and separate the person when if you're going to kind of go down the line. As we said, you want to keep it simple. You only want to cover what they want to know. You may not say much at all. But if they want to go down the line, you're trying to separate the person as the thinking, thoughtful, that kind of person, and separate it from their, if you can, body in that kind of way, rather than saying it as you are, because that's very labeling, isn't it? You're kind of giving them the identity of that
And I
thing.
think when we talk about the system or these systems, we
Yeah,
kind of dehumanize them a little bit.
yeah,
We separate them from, like as you just said, it's a very much a person-centered approach. They're
yeah,
they're the one being. They aren't made up of all of these, these separate systems. It's the one being. So I suppose in the last number of years, I've just tried to make my conversations and explanations much more person-centric rather
yeah,
than nervous system centric or immune
yeah,
centric.
yeah, yeah.
I think no matter which of those avenues we go down, we can easily land in hot water by again we're taking the person away from all of this.
Has there been any qualitative stuff about sensitivity, if we call it that, like people being having? But I know there's been qualitative on neuroscience education generally, but anything you're aware, I'm not aware of about
Yeah,
sensitivity
not
per
not
se.
not specifically on that. Obviously, there's a huge volume of work around the stigma and all of that kind of
Mm,
stuff, but it would be really interesting to look at the what we consider now to be better explanations
mm,
and to see are they being interpreted as we understand them.
yes,
And I'm sure in some people, yes, but in other people, no. And you know, when people say, "How do you explain fibromyalgia to the patient?" There is no one way of
no,
explaining it,
no,
and I might have to change tack
yeah,
in the middle of it. I might suddenly realize, no, this is the wrong approach, and it might take me a number of analogies to get it. But I suppose fundamentally, Ben, if you listen enough to the story
yeah,
and particularly listen to the experiences people will have.
yeah,
So when you give them an opportunity to tell their story, they'll often recall, sorry, times where, when they weren't sleeping very well, they felt more pain or they felt more anxious, or,
yeah,
when they were stressed, that in some situations they mightn't have felt any pain because we know that stress can be analgesic as well
yeah,
as hyperalgesic
yeah,
depending on the context.
yeah,
Or when they were away on holidays, they felt their pain a lot less because
yes,
they were walking more. And then suddenly it becomes less about me trying to explain to them, oh, this is the nervous system or this is the immune system.
yeah,
It's getting them to reflect on
yeah,
you can change your pain. Something is happening in your biology
mm,
when you're stressed
yeah,
or when you're taking a stroll on the beach. And in one scenario, you've more pain, in the other scenario, you've less pain. So your symptoms are controllable. You are in control of it.
mm, yeah,
That's more important. And it's very hard to argue with your own data.
exactly.
So that's much more important than giving them this arbitrary idea of what happens in the immune system and what happens in the nervous system that they may not even be able to relate to. They can't make sense of it in a real world environment.
Yeah,
So I would always layer the physiology on top of their own experience. So almost to kind of to drive that home rather than just giving them this handout on what happens in somebody
yeah,
with fibromyalgia because it's just meaningless.
it is absolutely.
And I think our education strategies need to reflect
Yeah,
their individual experiences and where they are and like how far down the road they are in terms of acceptance. Sometimes it might take 3 or 4 sessions before I even explore some of that. because they
Yeah.
may not be ready in those early phases. So
Mm.
it's knowing when and when not to bring something up or to discuss something in more detail. And look, I suppose that's a skill that comes with experience.
Yeah.
Sometimes it goes really well, and I'm sure you're just like me. Sometimes it doesn't go so well, and
Yes.
we realize, okay, that needs to be better. And
Yeah.
it's not that the patient just not getting what you've told them.
Mm.
You need to say, well, could I have done that better? Like
Mm.
what did I do well and what didn't I do so well there that I can learn from next time?
Yeah. We can't just assume that, oh, it's not working well because they're not accepting,
Yes.
right?
Mm.
Um, as you say, why? What happened in that explanation? You said about listening. Obviously, everyone talks about it. Let them tell their story, which is true, and most still very important. And you use your ears, but you said along the way picking up if it's not going well, and I think picking up on cues and what you see, and the evidence about body language is very unknown and uncertain. But you can, if you've even if you're early 20s as a clinician, you've had 20 years of life experience to get a sense of when someone's tuned into what you're saying and when someone isn't, and or if there's something going wrong. And sometimes people will want when they're saying something, they may say the words, right? But the what how they're saying it, the body language, the intonations with it may suggest something else. If you're discussing about after you've assessed them, you can see the kind of the eyes, not that eyes may roll, it's a very extreme example, but they may just you're just getting the impression that this isn't landing for any reason. So I always say, but you listen not just with your ears, but with your eyes as well, because that may tell you a lot more. Well, no, what do
Yeah,
you
and
think?
I think we need to talk with patients rather than at them.
Yeah,
As we're having now a two-way conversation, it's not about what's right and what's wrong.
yeah,
And that I always often say to the patient, look, you're the expert in your condition.
mm,
My job is to give you some understanding of what we might be able to do to help you achieve whatever goals you have, but it's not to tell you about your pain. You
yeah,
know more about your pain than I do,
yeah,
and just having that through, I suppose the motivational interviewing skills are very important,
mm,
as you've done a lot of work on. Reflective questioning, appropriate pauses, giving them time to ask questions.
yeah,
Clinicians can be guilty, I suppose, just talking, just
yeah,
reaming off the same stuff
yeah,
to patients all the time. And if that's out of context, of course, it's not going to land with the patient in front of you. And while it might be true, we might talk about things like immune function and sensitization. That's all true, but that's of no meaning if the patient doesn't relate it to their current condition or their current symptoms and where they are on their journey.
yeah,
So that's a challenge, and I don't think anybody has all the answers.
no,
And again, if you look at just explaining pain on its own, it's never going to change a whole amount of things because it's not. There's a lot more to patient care
yeah,
than simply trying to explain pain. It's what do we do about it? It's developing those coping skills, developing those coping strategies, and now how do you take that information that you've learned on board and then implement it so that it results in a behavior change that positively impacts on symptoms.
which is going to be we can't give people template on how to manage fibromyalgia. It's going to depend on, as you rightly said, what you hear, what's from what you hear and what you write down and what you note is impacting what's going on, those pieces of the puzzle, so to speak, and then addressing whatever it is. It might not be exercise. For some people, it can be absolutely, but for some people, it's they might want maybe they need financial help. They might need. I've had people who need to move house because
Absolutely.
of memories from the past. It's picking out what you hear and what you see, and then you may not be able to prioritize, but what are these parts
Yeah.
from what you've heard that is impacting that you then need to, or at least get other people potentially involved to help address.
And I
And
think then to add to that, we don't need to change everything.
mhm,
Changing one bit of the puzzle
yeah,
because we're so complex, changing one bit can lead to downstream changes and lots of other things. So
Yeah.
like, if you look at around like sometimes the focus might be on, okay, can we improve your sleep?
Mm.
Or can we look at regulating your sleep
Yeah.
before
Yeah.
we look at activity levels or anything else? But you will often find if we can change sleep, that the patient feels better. So now suddenly their mood is better.
Yeah.
So now they have more energy and by default they actually do more activity.
Yeah.
So, okay, it was a sleep intervention, but it was also an intervention that resulted in an increase in activity levels and
Yeah.
improvements in mood and
Yeah.
cognition.
Yeah.
I don't need to send them home with a sleep plan, an exercise plan. I sometimes see how it emerges. So
Mm.
how it develops. And again, that's through that regular contact with the patient, listening to them, getting their feedback, and where are we making progress and where are we not making progress? And that will shape who do I need to refer to, or do I need to bring somebody else in with the expertise? Does this need a more structured CBT approach to improve your sleep? Do I need to bring in a clinical psychologist into this?
Mm.
Or is there just a barrier? Is there an ongoing depression that's just poorly controlled, and we need to
Mm.
talk with the GP about how can that be managed in a different way?
Yeah. Yeah.
Rather than thinking just you just need to take more steps, or you need to take 10,000
Mm.
steps a day because that's what the public health guidelines say we should do.
Oh, yeah.
The messages are often lost in translation.
Yeah.
I always say is that, you know, by asking about things like sleep and mood and all of these things, that doesn't make you biopsychosocial in your approach.
Mm.
What makes you truly biopsychosocial is understanding, okay, how do we devise a strategy or a treatment strategy that incorporates that bigger model? And
Yeah.
where am I likely to get most value by targeting
Mm.
first? If somebody is sleeping 3 hours a night, they're never going to get to 10,000 steps a day.
No. No.
Their fatigue is just, it's exhausting.
Yeah.
You're telling them they need to exercise more. They're telling you they can't do that because they're absolutely exhausted. So
Mm.
now they go home angry that you really haven't listened to them
Yeah. Yeah.
because they're so tired,
Yeah.
and fatigue is debilitating.
Yeah.
So okay, improving sleep might not be that simple, but it's clearly something that
Yeah.
we need to work on. And it's not one or the other, but I think we need to be careful with recipes and what people
Yeah.
should do and shouldn't do. And we don't have a recipe book for how do
Yeah.
you manage fibromyalgia. It's just not there.
Mm.
They're overarching principles. Yes, we'd love to get people more active. We'd love to get everyone sleeping better, get their mood better. Easier said than done
Of course.
for anybody.
Yeah.
So it's looking at what's the simplest way that I can make the most change in the short term, implement that, see how the patient progresses or doesn't progress,
Yeah.
and then reevaluate with the patient around, okay, what's working, what's not working, where do we need to go with this? It's it's a roller coaster for sure.
Yeah.
It's definitely not linear.
No. And we should point out to people that, you know, that may sound complex, that there's no template, right? Or there's no script. But in a way, and it may be just from experience, but I find that in a way easier because if you've listened properly and you've got the relevant factors and you've, hopefully asked the right questions, then they've told the classic phrases, they'll tell you the solution, the answer.
Yeah,
It'll be there. And like you said about, they went on holiday and they noticed their pain was better, or when their sleep was better, they're almost like retrospective behavioral experiments, aren't they? Uh,
absolutely.
they've pointed it out. You can use that evidence and then lay
Yeah.
it out, essentially.
And I think that's far more important than getting into the neuroimmunology
Yeah,
of
yeah,
the condition.
yeah,
And going back to what I said at the very beginning of our chat, you know, please don't see this as that you ignore so-called issues in the tissues.
yeah.
It's quite common that I might give somebody some specific exercises that are addressing they've lost function in their right knee because they have knee OA and they're afraid to load it, and they've lost quads function, and that means they can't climb the stairs,
Mm.
and it's clearly limited by their knee as much as it is by their broader fibromyalgia symptoms.
Yeah,
It's quite okay that I can give them specific exercises to try to improve the capacity and function of their right knee
yeah,
concurrently where I might be working on their sleep.
Yeah.
or I might address all of these other factors. I don't have to see this as this is my problem with this whole primary versus secondary pain stuff. I'm not sure patients neatly sit into these
No.
boxes.
No.
We probably all have ongoing nociception in us all the time.
Yeah.
So to say that somebody doesn't have any issues in the tissues is probably a bit far-reaching
Yeah.
for the vast majority of people that aren't probably doing a lot of exercise, that are deconditioned, that may have put on weight. There's going to be some issues in the tissues, and I'm not saying that that has to take priority, but we'd be naive to think that the health of the tissues
Mm.
isn't a part of a bigger picture.
Yeah.
So I do worry about this primary versus secondary and kind of labeling somebody, because I think that's why diagnosis go under the radar for a long time.
Yeah.
Because once you've been given the label of fibromyalgia, everyone assumes that you
Yeah.
don't have anything inflammatory, and your right knee being sore, oh, that's just part of the fibromyalgia.
Yeah.
Yes, yes, in some ways it is,
Might be. Yeah. Yeah. Yeah.
but it's still something that we can address.
Yes.
So there is a role for, I suppose, the traditional tissue-based model,
Yeah.
but once it's incorporated within a much broader, truly biopsychosocial model of care.
Yeah, agree. If you, yeah, that, and they will often, if they've had it for a long time, they'll say, I go to my any, well, it doesn't be GP, but anyone, and they'll say, oh, it's because of your fibro, or it's because, and no, it
Yeah,
might be. We should be clear, it could be, but it
yeah,
might also, as you rightly say, not be. People can easily have fibro and whatever.
absolutely. Yeah, and
Fun,
they often do.
yeah,
It
yeah,
mightn't be a very classic thing like an inflammatory condition, but it may be more subtle. They may
mm,
have, as I said, I'm using osteoarthritis because it's just so common in the general population. Or, I suppose like another classic one, fibromyalgia being much more common in females, we tend to see gluteal tendinopathy often correlate with more widespread pain.
yeah,
And is that worth addressing? Most likely, yes, because if it gets them sleeping better, if we can change the position so their hip hurts less at night, now they sleep better. Now that
mm,
has another impact on their overall symptoms like fatigue and other stuff. So
yeah,
I think we need to be careful about our explanations, and that we don't go down the role of pathologizing the tissue, so to speak.
mm,
But we can talk more generally and saying, okay, look, there's a lot of things we can do to help you with your knee or your that hip pain you're having, that may have an effect on these other symptoms. And then when they do see the effect, oh, I'm sleeping better, and I've noticed that my other pains and aches are a lot less now.
yeah,
Now suddenly, again, their own data is very hard to argue with.
yeah, yeah,
You don't
exactly.
have to convince them anymore that
No.
that sleep was playing a role in their symptoms.
Yeah, it's just you can just use it as evidence, can't you? It's just
Absolutely.
there.
Yeah.
We'll finish this on how often these appointments do finish, and I'm sure anyone listening to this will get the question, which especially if it's they're new in the journey, they'll get the question of, will this go away? Will this get better? And you look online and it will say this is a long-term condition to manage, and for many people it is. But I never want to sit here. My classic line is, I will never sit here with the crystal ball and say you will be like this forever. I also say to them, but we will not sit here and say in 6 months' time you will be able to do da 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 da, because life happens. We can't predict things. We can, from what we know from experience and from the evidence, we can improve your quality of life. Hopefully, can get you doing more of what's important to you, and hopefully, pain interferes less in your life. Um, I'm not going to say that it can't, because I have seen people where something changes, whether it's one thing or collection, and actually they are. It's very rare, but they are pain free. Um, I can also tell you there's people that get worse as well.
Yeah. Mm.
Um, I often describe it to them, and this doesn't land as well with the younger ones these days. It's less of a thing. But back in the TV on the day, there was a person who was spinning plates on the sticks. And anyone over, I don't know, 30, 25 can relate to that. I'd say it's how well those plates can keep spinning. Sometimes they spin really well, sometimes they don't. And it's how we can help you control them as much as possible. What do you say?
I agree. I think you're right. We have to be careful not to overpromise.
Yeah.
We don't have a crystal ball. These are complex conditions. just are things like diabetes, cardiovascular disease. Nobody's going to say you're never going to have a hypo, or you're never going to have to do this. And I think we need to be careful that we don't say, look, I have the approach that's going to get you better. Your pain is going to be gone.
Yeah.
We don't have the evidence, nor the clinical data to back that up. But I am a believer in that we need to be optimistic. We need to look at things that we can change. And you've alluded to some of them. We can change your function. We can get you engaging more with things that you like to do, improving your quality of life. And very often we will see an improvement in symptoms when when you do that. So one of the things I like about the acceptance and commitment therapy literature is that there is an emphasis on, getting people back to doing what they want to do. But I'm also of the belief that pain fundamentally impacts on what we want to do.
Yeah.
So it's not simply a case of just do what you want to do despite having pain, because we need to be realistic that pain does, and it limits function in all of us.
Yeah.
You know,
Yeah.
like I had, I kind of use my own experiences. I don't have a history of any persistent pain, but I've last year I had a quite a nasty stress fracture that
Oh.
was quite painful. And I couldn't run. There was lots of things I could do.
Mm.
So the acceptance and commitment therapy work would have me focus on the things that I could do, but
Yeah.
regardless of how optimistic I was, I couldn't run. So the
Yeah.
the
Yeah.
pain was just, obviously I couldn't run because I knew I had a stress fracture anyway,
Yeah.
but the pain was limiting me. It just
Yeah.
was fairly severe. And no matter what else, I wanted to run.
Yeah.
I was happy that I could walk without pain after a number of weeks. I could still work. I could do all of those things that did add to my quality of life, but I couldn't run
Yeah.
because of pain. It wasn't because how I was thinking about pain or how I was understanding pain. I
Yeah.
just couldn't run because I had pain. So pain does stop people doing what they want. So I
Yeah.
do think we do need better treatments for pain, and I've been on record for saying that. And I would give people, some optimism without overpromising it, that if we can improve all of these other things,
Yeah.
very, very gradually, albeit, we know that we often don't see changes in symptoms for 3, maybe 6 months. So setting them up for realistic expectations in terms of timeframes,
Mm.
and that doesn't mean that they'll feel pain or less all the time. That
Yeah.
it very well may fluctuate.
Mm.
They very well may get flare-ups. People with asthma get flare-ups despite it being well controlled. People with
Yeah.
rheumatoid arthritis get flare-ups
Yeah.
despite it being well controlled. Flare-ups are I won't necessarily say an inevitable part of the process, but they're not far off that. It's
Mm.
it's very important that we don't take pain out of the equation, but
Mm.
equally that we don't overpromise that they'll be pain free.
Yeah. Yeah.
And I'm quite happy to say to somebody, let's go on this journey.
Yeah.
We will see how you're progressing, what things are improving, what things aren't improving, and we'll reassess this in a number of weeks. So again, that conversation isn't a conversation that just happens on day one. It happens over time, and it may or may not change depending on how they're progressing or not.
Mm. Absolutely. Absolutely. Yeah. Realistic optimism. I guess that's what we're after, isn't it?
Mhm.
Were there things you want to say that we haven't asked or we've missed?
No, I suppose just on my last point around preparing people for how to manage flare-ups, or at least
Mm.
having some kind of a plan in place
Yeah, that's true.
is very important, because flare-ups are oftentimes in people's journey where they can either learn from it and actually use it to their advantage,
Mm.
or get totally disillusioned with the whole thing again and realize, oh, this isn't helping
Yeah.
me, and you won't see them again. So again, preparing them very early in
Yes.
that journey, that you may flare up. If you flare up, we'll have a conversation. It may be something I did that it's not the patient is to blame.
No.
We may have set unrealistic targets around activity levels or whatever it might be that we do need to pull back in.
Yeah.
And it's a two-way street. It's not about blaming the patient. It's not about blaming the clinician. It's about saying, okay, what could we do differently next time to reduce the risk of that happening again? So actually we're learning through experience, both the clinician and the patient.
Well, yeah. Yeah. And often so say to people, if you have a plan, and they would have had flare ups by the time they're coming to you, they wouldn't be in front of you if they hadn't had flares at some point.
Yeah.
If they've had a flare, and you can say if you've got a plan, then typically, okay, just from experience, the flare doesn't last as long and isn't as severe when it happens.
Yeah.
And that in itself sounds quite appealing to them. And you can, go through it with them, often to get them to do things like obviously give them relief, help them relax, movement they can do, and then you reiterate the pacing and other important aspects that depending on their story. But even just having it written down and easily available, just so they know if this happens, I can go. I've got this,
It
just do
it
this.
it, it de-threatens the scenario, doesn't it? And
Yeah.
it just gives them permission that it is okay if they need to back off, if they need
Yeah.
to reduce their activity levels. You know,
Yeah.
they don't need to be seen to be pushing through this. It's not necessarily advantageous to fight the pain or to be, go back to where we started this conversation
Yeah.
about pushing through it because they want to
Yeah.
be seen to be strong, and
Mm.
people don't believe them, so they feel they need to fight the pain, and they need to look tough, and that pain is a sign of weakness, and all this kind of stuff that we'll hear in the public. Just giving them permission that actually it's quite sensible in a flare up to just allow your system to recover, reflect, figure out what might have contributed to it.
Yeah.
Back off for a few days if you need to. Give me a ring and we'll chat it through.
Yeah.
But don't panic.
Absolutely. Absolutely. Um, you and I are both doing the Therapy Live talk. I think it's in a couple of weeks, mid-August. I think yours is on Fibre, isn't it?
Yes. Yeah, the end of August, the
August.
last Thursday, I think, in August, or towards the end of August, anyway. Yeah.
We'll leave people with the a hook to go and look, and I'm sure Jack will like the promotion. Anything else you want to say or cover?
No, I think we've covered a lot of the common questions that come up both with clinicians and with patients on a regular basis. Yeah.
And I hope you haven't. I think if I said we'd do it as discussion rather than just me firing questions at you. I hope people value the different experience and the different, sometimes hearing it from multiple people helps just give it clarity. Yes.
I think it's better, yeah, because as I said, there's no right and wrong with this.
Mm.
It's around pulling on your expertise and your experience and formulating it in a way that works for you.
Absolutely. Cool. Thank you, Derek.
Excellent. Thanks, Ben. Enjoyed it.